So this slide is the expected outcomes. So this is a high-level framework, as I mentioned. It is meant to have province-wide application and to help guide Ministry of Health and health authorities, as well as NGOs, when they're trying to develop and configure a stroke rehab system. I want to emphasize that the collaborative really wanted to include a community piece into the framework, as this area hasn't really received a lot of attention in the past, and much of the stroke survivors' rehabilitation actually takes place in the community setting, and it has been identified in the past as a phase of stroke survivorship where service delivery can be quite confusing and heterogeneous, and certainly to the patients. There is also an addendum document that Diane mentioned to the service delivery framework, and that addendum document actually contains a set of worksheets that acts as a tool to help administrators assess how well their own regions or centers is actually meeting the stroke rehab standards. And this tool can then help you identify specific areas of need or gaps where the resources can then be directed during your planning phases. So the key steps of the service delivery framework is to start off, first of all, by identifying the initial stages of stroke care. And so this is usually from hospital assessment and then progresses all the way out to community living. The stroke rehab and reintegration work group did consist of representatives from pretty much all the health authorities since especially with the meetings that we had in 2008. I think as we progressed along during the development of the framework, we didn't have as much input from Northern Health as we would have liked, but certainly we tried to keep your needs in mind. We also had involvement from the Stroke Recovery Association, and then of course the consultants from the Heart and Stroke, BC Stroke Strategy. So we looked at existing service delivery frameworks and came up with some underlying principles and goals. So the first thing is to identify the stages of rehab. And the next step was to look at how current facilities may fit into a set of designations. And I'll talk more about that later. And then looking at the actual models of service provision and the algorithms, and then a set of recommendations for evidence-based standards. We did compare several different service provision models, as I mentioned, and algorithms before ending up with the ones that you'll be seeing today. And we try to really keep it to a practical level and select a shorter list of evidence-based recommendations that are more clinically relevant. So while we were developing the service delivery framework, we were also cognizant that there was other work going on in stroke care, including the acute stroke work group, the ACVS group, as well as the fact that several health authorities were also looking at examining and reorganizing their own stroke and rehab services. So we wanted our framework to be able to align with these other pieces of work so that we don't have differing recommendations and that the overall strategy is cohesive. So this is also part of the reason why the framework is not meant to be a prescriptive document, as there needs to be enough flexibility to allow the health regions to adapt the framework in a way that would best work for their region. So we met 3 times from November to May, so that's November of last year to this May, to look at the evidence, discuss the definitions, and develop an approach. And we did connect, as I mentioned, with the acute stroke side as well, to make sure we are consistent with what they're trying to do, and then discuss the strategies and operational concerns. So this slide really just shows you the 4 main stages of stroke rehabilitation and reintegration that we identified. It's important to note that the stroke rehab principles are applicable through all stages of stroke care. And the key is to actually maintain continuity and integration. But for ease of administration and planning, we have divided up into these four main components. So the first one is the hyperacute, and this is really the first 48 hours after a patient presents to hospital and the stroke has been diagnosed. So the focus is really on getting a patient access to a stroke unit where an interdisciplinary team with standardized assessment tools can then assess the patient and develop a triage plan. Once the stroke is diagnosed, patients in centers that do not have a stroke unit should be considered for transfer to a facility where those services are available. The second stage is then the inpatient rehab. Now, just keep in mind, not everybody will have to go through these stages in a linear fashion. There are, of course, patients who don't require inpatient rehab and can go straight into the community. But in terms of the inpatient rehab piece, this is a formal, coordinated stroke rehab service with an interdisciplinary team. The team should meet regularly so that goals can be established and is patient-focused. The therapies are provided with the aim to maximize recovery potential. It is also a setting where a lot of education can be delivered to patients and families. The community rehab needs should be assessed, and the planning for that should be initiated while the person is still in inpatient rehab. The third stage is the community rehab piece. This is mostly ambulatory. It can be either based in a facility or based in the home. The specific services and disciplines involved will depend on the actual patient's needs. And there is increasing evidence that early supported discharge is an effective means of providing rehab to those who have relatively mild to moderate stroke severity strokes, as long as it's delivered in a timely and coordinated manner. This stage of community rehab also involves community programs and wellness groups that can help to support the survivor and their family in the home setting. The fourth stage is community reintegration, and this is really focused on maintenance and enhancement of the stroke survivors' social and vocational ambitions, and really to try and get the patient to become more empowered to self-direct what their needs are, to gradually become less reliant on formal therapies, and to truly reintegrate back into a lifestyle that's going to be compatible with their residual impairments. So this is where we need to work closely with community partners such as Stroke Recovery Association or Brain Injury Associations, as well as other already established community programs that might be available in rec centers and community centers across the province.